一応これを YouTube に載せてるからな。うん、後から、うん。あんまりちょろっとこう知り合いしくじゃないけど。Anyway, I will talk about another type of kinematic alignment. So this is so-called soft tissue respecting kinematic alignment. That means the bone cut plane is decided by the ligament balancing. So it is quite popular procedure in Japan. So most surgeons use this technique. And some surgeons misunderstand this technique is Calipered kinematic alignment or true kinematic alignment. But this is completely wrong. Completely, this is misunderstanding. Because this cutting plane is decided by referring to the femur component, femur cutting plane. So this is a dependent cut. This cutting plane is decided depends on the femur cutting surface. But Calipered kinematic alignment or true kinematic alignment, the bone cut plane is decided based on the tibia morphology. So that is the independent cut, not depend on the femur side. But many Japanese surgeons want to apply gap balancing technique. So this technique, the purpose of this technique is balanced gap in extension. How to do this? To cut the femur first. So because as I described yesterday, the most femur side has the safety range, LDFA. So in terms of femur side, we don't need to make this restriction. We can follow the native patient joint line of obliquity of the femur side. Do you understand? We don't need to manipulate femur side alignment because most patients fall into safety range. That is considered as plus minus 5 degrees from the mechanical line. So, but tibia side is different. Tibia side is most patients have the out of safe range. So, for example, 5 degrees Vedas or more. But femur side, we can simply follow the patient native slope. So, in most technique, femur side is cut independent. So regarding the distal side cut is lateral side is 9 millimeter and medial side is 7 millimeter, compensating for the 2 millimeter thickness of cartilage. Okay. Then regarding the posterior cut, 9 millimeter, as long as there is no cartilage wear on the posterior contact. So this is dependent. There is no consideration about the tibia side. So this is dependent. So most surgeons say that kinematic alignment as femur-driven surgery. Decide everything, the femur first. So reconstruct the cylindrical axis. So this is the flexion extension plane of tibia. So do you remember? Do you remember? Well, I explained 3 mechanical axes, the beginning of this one. This is the green line, the flexion extension axis of tibia around the femur condyle. This is simulates the cylinder. In other words, the sinus radius shape. At least 30 degrees to 120 degrees reflection. Okay? The the first purpose of kinematic alignment and make this line, cutting the same thickness as the component. Okay, then make the tibia cut. There is a two way. One way is only referring to the tibial side. So lateral side 10 millimeter and medial side 8 millimeter. This is the true kinematic alignment, Calipered kinematic alignment, or in other words, independent cut. Another way is this approach. If we cut and make the same inclination slope medially and posteriorly, that can simulate the patient native joint line. The femur side reconstruct the patient native joint line or joint surface. And the tibial side reconstruct or restore the patient native joint line. Then combine in the operation. The ligament balance can be adjusted because in the predicted condition, the all ligament or the all soft tissue balance is achieved already in predicted condition. So this is a measured approach, so independent approach. Make the femur side perfectly and then make tibia perfectly. Then gap can be adjusted automatically. This is a dependent approach, independent approach, measured approach, and Caliper approach. Anyway, the another one is that in this approach, the final goal is reconstruct the parallel gap in the extension. Because even in the normal population, that the most of normal population has loose flexion gap. Maybe I show the paper from Osaka City University. It's very simple, applied valgus beta stress in 90 degrees reflection and take the MRI and compare the medial side to lateral laxity. In the lateral side, it is looser than the medial side. It is very agreeable because in the during the arthroscope, we always the figure 4 and apply slide beta stress. So we can access the lateral side very, very easily. But the medial side is always tight, especially in the osteoarthritis patient. So anyway, so what I want to say is the flexion is always lost. But in extension, gap should be balanced, at least for flexion. Once the knee flex a little bit, around 10 or 20 degrees, lateral side comes lower. But even in the 20 degrees and mid flexion and deflection, medial side should be stabilized. Anyway, so it is ideal to make the parallel gap in full extension. So using this theory, cut the distal end parallel to the distal femoral cutting plane. And that is reasonable because if we cut like this, we can easily make the ideal extension gap that is parallel and same thickness as component. So how to do this? Quite simple. Put on this spacer at the distal pattern surface of femur and draw the line on the tibial surface. That's quite simple. Under the inline traction, the leg is tracked in the foot direction. Simply pull the leg. Then both ligaments can be restored these normal length. So as the time to make the line, that is quite simple. But problem is, so we cannot decide the true this level, cutting level. So we know the cut should be made parallel to this line, but the level should be decided using tibial cutting block and stylus. Okay, but this is a kind of unrestricted kinematic alignment. At this point, we never refer to the total alignment. Total leg alignment doesn't matter. The purpose is only restore the normal ligament balancing at floor extension. You understand? But this is quite a similar procedure to the Oxford knee. In the Oxford knee, we don't care, we don't mind the total leg alignment. So we just restore the patient normal soft tissue situation. More precisely, restore the normal native MCL length and tension in extension and flexion. So that's all. Total leg alignment doesn't matter. And furthermore, so morphology is something different from the patient native condition. I'm saying about the Oxford, because shape is completely different. The component is completely single radius, but normal condyle is multi-radius. So, or there is some difference in the joint line on the component Oxford knee and the native joint line like this. That's why we need anterior mirror using the unicorn. So that implies that there is a difference. So to make the balance gap in flexion and extension, Oxford changed the shape of knee. So Oxford knee is not a true resurfacing. So to resurface completely, we need to use multi-radius fixed bearing. Fixed bearing is simulate the patient native joint line, but Oxford is complete. Anyway, so this is similar. In this procedure, the final goal is make the balance gap in the same gap in flexion and the extension. Okay, do you understand? This is not published in the world, but very, very popular in Japan. Most surgeons use this. Okay, わかった?わからん。わからんか。要は、この等しい進展ギャップを作るために、足を引っ張って平行に切ろうと。ギャッパーってそれ。そう、ギャッパーはこの、もうこれをやらんと、やっぱりに、こんなこと言ったら、録音されてるから。もうやっぱ日本の先生、これせんと気が済まん人が多いね。